Before we start our conversation about identifying a sick patient, it's helpful to define the word sick. Certainly, you could poll a variety of people and ask them what the word sick means and receive a variety of answers. As emergency clinicians, we work in a place that has over its doors in big red letters the word emergency. Subsequently, everyone there thinks they are sick. Most people with the common cold will tell you they are sick. For the purposes of this conversation, let's identify sick as a time-sensitive, life or limb-threatening emergency medical condition. So what are we talking about? Patients who require intervention to prevent morbidity or mortality. I think it's pretty obvious to most that a 50-year-old man with diaphoresis, pallor, and conversational dyspnea is sick. But would it be obvious if his only finding was a resting tachycardia? Let's take a system-based approach to identify the sick patient. This is the section where we say to ourselves, I walk into the room and what do I see? Much of this assessment is the doorway assessment, where we use our 5 senses to get an idea of what might be happening with our patient. What do we see? What do we smell? What do we feel? Here are some examples. Hello, sir. I'm your provider today. What's your name? Are they awake, alert, and oriented? Do they know who they are and where they are? Can they tell you what brings them? Are they awake enough to protect their airway? Are they sitting upright or are they supine? Are they using accessory muscles? Is the tripod position present? Are they standing? If so, are they pacing? Are they moving symmetrically? Are they diaphoretic? Diaphoretic patients are scary. Patients can fake lots of things, including seizures, shortness of breath, and pain. They can't fake diaphoresis. If a patient is diaphoretic in a climate-controlled setting, they are sick until proven otherwise. Also, do they have normal skin condition and tone? Are they pale? If you choose to touch your patient during this part of the exam, you might notice delayed capillary refill. Although we will address this more later, an astute clinician can get quite a bit of information about the respiratory status of a patient just walking in the door. Can they speak in full sentences? Are they sleepy? Remember the part about general posture and tone? That's connected to this as well. On occasion, you will find other pertinent issues simply via the power of observation. For example, you may notice the patient is disheveled, which could give you some insight into their thought process or perhaps their living situation. Maybe you notice vomiting and diarrhea. Maybe you notice obvious injuries or bleeding. Perhaps you notice the smell of urine, blood-mixed feces, or ketones if you're one of those who can smell them. All of these data points can help paint a picture of the patient in front of you. Now, let's take a brief system tour so that we can understand other indicators of illness. The head is most easily examined with visual inspection. There are many times when it is appropriate to palpate the skull as well. What are we looking for during the exam? On visual inspection, look for obvious signs of trauma to include bruising and bleeding. Is there any fluid leaking from the head? During palpation, feel for soft spots, which may indicate fracture or other trauma. Is there anything painful? If your patient complains of headache, are you able to palpate a tender temporal artery? Hair loss may give you some clues to thyroid disease, and in the right setting, could clue you into an endocrine emergency. Obviously, we can get into the weeds here. There are several ways to evaluate the eyes, but let's focus on the cursory evaluation of the eye that we can do without a slit lamp or special tools. First, evaluate the pupils for size, shape, and symmetry. Remember that a certain percent of the population will have unequal pupils, but they typically know. If they can't speak to you, ask their family. A teardrop-shaped pupil may indicate rupture. Look for hyphema. Is there swelling around the eyes, which could indicate basilar skull fracture? Let's focus on what we can see with the naked eye. Is the ear still attached? Yes, that's a serious question. Do we see fluid draining from the ears, such as CSF otorrhea, indicating skull fracture? Is there blood coming from the ear? Do the ears work? Can they hear you when you speak to them? Is there any bruising behind the ears indicative of skull fracture? Not much to see here, but the same rules apply. Any obvious trauma or deformity? Is the nose bleeding profusely? Is CSF draining from the nose in our head-injured patient? Listen to their voice. Let them speak to you. Is it normal or is it muffled? A muffled voice may indicate abscess. Look into the throat. Is there any deviation of the uvula? Do you see any pus? Any obstruction? Are they swollen? Angioedema should cause you to be frightened. In general, the neck is the part of the body connecting the head to the body. Despite its small area of real estate, it contains many important anatomical features. The spine and spinal canal is there. Blood feeding and draining the brain lives there. Air enters the body through the neck, and it's the main conduit of nutrition. Subsequently, lots can go wrong. Let's explore a couple of these and how we might find them. Regarding the spine, look for asymmetry or tenderness to palpation. Is there any penetrating trauma? When you do the neuro exam, which we will discuss later, is the exam consistent with cord injury? When you palpate the anterior neck, do you feel subcutaneous air? This could represent injury anywhere in the aerodigestive tract. How about obvious trauma, especially penetrating trauma anteriorly? Do you notice any deviation of the trachea? Be careful about this because the cervical collar may block your view. If you want to be sophisticated and use a stethoscope, listen to the carotid arteries to assess for a bruit, which represents turbulent blood flow. The thorax is bordered by the clavicles superiorly, the diaphragms inferiorly, and is surrounded by the ribs anteriorly and spine posteriorly. The thorax is home to many important structures important to the maintenance of life. Let's discuss some exam findings which may be problematic. For a thoracic evaluation, we will use our ears to listen, eyes to assess for symmetry, and hands for palpation. Inspection. Look for equal chest rise with breathing and determine the respiratory rate. Is it too fast, too slow, or just about right? Do you see any floating or flail segments? If the patient reports traumatic pain, palpate the chest, feeling for crepitance, tenderness, and subcutaneous air. Listen. Several things are identified through auscultation. Listen for heart sounds. What's the rate? Knowing an exact number is not important here. Just get a general feel for speed and regularity. Do you hear any murmurs? Remember, murmurs represent turbulent blood flow across a valve, and a new murmur can represent a catastrophe in the right setting. Also, listen for extra heart sounds, such as gallops, which may represent congestive heart failure. Regarding lung sounds, do they have wheezes, representing bronchoconstriction? Do they have ralls, representing fluid? Are they diminished, perhaps because of effusion or pneumothorax? What's the rate and regularity of the respiratory effort? Does the pattern or quality represent compensation for a metabolic issue, such as a patient with diabetic ketoacidosis? One other note of mention, palpate peripheral pulses. Why? It gives you a sense for heart rate and quality, but also helps give you a snapshot of blood pressure. No radial pulses bilaterally? You know automatically that blood pressure is too low. This seems like a good place to mention this. We often use pulse oximeters to know the patient's oxygenation status. The more pulse oximeters stuck to the patient, the more likely you are dealing with someone in a shock state. A word of caution here. We don't spend much time thinking about the posterior thorax. Remember that pathology of the posterior thorax may present as atraumatic back pain, so always maintain this in your differential. The abdomen is so much more than just a magic box full of guts and organs. It is helpful to imagine the abdomen as the sum of its component parts and to think of every quadrant of the abdomen. As you recall, the abdomen is typically divided into 4 quadrants with some overlap at the epigastrium. As you examine the abdomen, consider the pathology that could be lurking therein. For example, in the right upper quadrant, your patient could have gallbladder or liver pathology, perforation of the duodenum, or kidney issues. In the left upper quadrant, consider pathology related to the stomach, spleen, or kidney. In the right lower quadrant, consider the appendix, GU tract, colon, and any reproductive organs. Similarly, on the left, consider colonic pathology, reproductive pathology, and urinary pathology. Palpate the epigastric area and consider pathology related to the biliary tree and stomach. The suprapubic area should be examined because it is the home to the urinary bladder, uterus, and GI tract. As you examine the abdomen, look for guarding, rebound, or rigidity, which can all be signs of peritonitis. Is the abdomen distended? You might be wondering about bowel sounds. These are of limited utility in the emergency setting, but should be evaluated prior to palpating the abdomen if you choose to do so. Abdominal pain is among the commoner complaints in the emergency department. Subsequently, it can be easy to fall into a sense of complacency with the abdominal exam. Just remember, the abdomen is home to some important organs and can house a number of life-threatening emergencies. The extremity exam can demonstrate some potential emergency medical conditions. For starters, the limb must be evaluated for entities which are life-threatening. Is there swelling? If so, is this bilateral, such as CHF or chronically poor perfusion? Or is it unilateral, such as a DVT? Do you see signs of injury, such as deformity or bleeding? What's the pulse situation? They should be equal bilaterally and palpable. If they aren't palpable, is it because of acute occlusion, or is the patient in shock? Peripheral pulses can provide insight into rate, rhythm, and quality of cardiac output. Is movement symmetrical from one side to the next? If not, why? Is the patient experiencing an upper motor neuron issue such as a stroke? Do they have a spinal cord issue? Or is there localizing trauma preventing movement? The extremities can provide insight into the neurological, cardiovascular, and musculoskeletal systems. Therefore, the examination of this area is of utmost importance, especially in the undifferentiated emergency department patient. As long as you're evaluating the extremities, it may be wise to go ahead and evaluate the back and neck, especially if something in the chief complaint suggests that it is necessary. Check for midline tenderness, deformity, wounds, and other signs of injury. Think about the things that can cause atraumatic back pain, and remember that a good back exam can help rule these in or out. We will discuss back pain by itself in later chapters, but for now, let's agree that the back should be evaluated more often than we probably do. While examining the extremities, this is an excellent opportunity to evaluate the neurological system. You have already assessed the mental status when you entered the room. You identified the patient's tone and have noticed whether or not they can follow commands and communicate. The Glasgow Coma Score, or GCS, was created to evaluate victims of neurological trauma, but serves as a useful way for us to track the mental status of our patient. Remember that beach balls and dead people have a GCS of 3, and if you have normal mentation, your GCS is 15. The nice thing about GCS is that it allows for an objective measure of mentation as the patient is handed off from one caregiver to the next. Some like the mantra, less than 8, intubate, but you will need to decide this on a case-by-case basis depending on your diagnosis and other clinical data. Besides mental status and the ability to follow commands, there are a few other key elements of the examination worth mentioning here. First of all, what's the face telling you? Is it the same on each side? Ask your patient to smile and determine if it's the same across midline. Do you see any obvious cranial nerve deficits? Subtle difficulty with extraocular muscle movement may be hard to find, but if suspicious, test to see if your patient has any double vision in any field of view. Secondly, are the extremities demonstrating symmetrical strength? If not, is it because of a localized injury or disability, or is it the cause something from the brain or spinal cord? Remember that not all causes of asymmetry are stroke, so be diligent in trying to determine the cause of unilateral or asymmetric weakness. Is there any ataxia? This could be truncal or could be demonstrated in finger to nose or heel to shin testing. An often overlooked yet very important aspect of the physical exam is to see the patient walk. Granted, this is not always possible for a variety of reasons, but a good rule of thumb is that a patient who could walk yesterday but can't today is sick until proven otherwise. As we get into the bushes of the physical exam, there are just a few considerations here. With regards to females, high volume blood loss from vaginal injury or pregnancy complications can require a massive transfusion. Pregnancy-related emergencies get their own chapter later on, but a good exam may provide some insight into pregnancy status, especially after the first trimester. With regards to men, testicular pain is a common emergency department complaint, so be sure to note any testicular tenderness or abnormal testicular lie. Blood at the meatus may tell of a urethral injury, and scrotal bruising in the setting of trauma may foretell a pelvic fracture. Scrotal cellulitis involving the perineum could represent a life-threatening polymicrobial infection. You don't know unless you look, so don't be shy. The last organ system we will discuss, albeit briefly, is skin. We have alluded to some sources of skin pathology in other sections here, but it is important to drill down on a couple of these. First of all, be on the lookout for injuries to the skin such as burns or lacerations. Is the wound tetanus prone? Does the wound require repair in the emergency department or perhaps in the operating suite? If burned, does our patient require the burn unit? Sacral decubitus ulcers and diabetic foot wounds are common sources of infection and potentially sepsis, so be sure to look at the feet, back, and sacrum, especially in patients who are unable to provide much history. Be able to identify dangerous rashes, such as those causing petechiae, and those which may be signaling a dangerous inflammatory response. Luckily, few rashes are dangerous, but you have to know the ones that are. A valid question you may have asked by now is, so what's the point of all of this? Good question. There are actually a few points. First, if you know where to look, the body will do a remarkable job telling you that there is a time-sensitive, life or limb-threatening emergency medical condition. The items listed above are nowhere close to being exhaustive, but merely demonstrate some common places you may find evidence of sickness. Secondly, most of the clues we find are isolated with simple use of our senses: visual inspection, palpatory examination, hearing voices and thoracic sounds, and a few occasionally unpleasant smells. What's missing from the list? Technology. The cardiac monitor is missing. Why? We don't need it. Well, not to determine sickness anyway. We can use the monitor to confirm what we already know about the patient and to further hone our hunches. You can still identify a sick patient when the power goes out and the batteries die. If you are basing clinical decisions based solely on the cardiac monitor or other technology, there is a chance you may be missing something or delaying life or limb-saving care. Good luck, and may your senses continue to guide you to make great clinical decisions. For Team Health, I'm Dr. Patrick Cody. Thanks for watching.